Welcome everyone. We're going to have an exciting session about how blood pressure control and home ECG monitoring help to prevent strokes. Hypertension is something that is much more frequent than we would ever think. We have different definitions. So a normal blood pressure is where the systolic blood pressure is lower than 120 millimeters mercury, and the diastolic should be lower than 80 millimeters mercury. If the patient enters the pre-hypertensive phase, the systolic blood pressure is up to 120 to almost 140, and the diastolic is between 80 and 89. That's the definition of pre-hypertension. Once we enter stage 1 hypertension, systolic blood pressure is defined as 140 to 160, whereas the diastolic blood pressure is defined as 90 to 100. Stage 2, systolic hypertension, 160 millimeters mercury or more, and the diastolic is 100 millimeters mercury or more. So these are the definitions: pre-hypertension, stage 1, stage 2. Here's some more facts on hypertension. It's the most common primary diagnosis worldwide, the number 1 risk factor affecting our global health. And it's a major risk factor for stroke, myocardial infarction, vascular disease, and chronic kidney disease. Here's some more facts for you. The worldwide prevalence of hypertension in the adult population, as we have it in the Western world, is around 30 to 45%. This is certainly not trivial. The prevalence of hypertension in Europe ranges from 9 to 20% in the entire adult population, and ranges from 44 to 60% in the elderly population. Big numbers, right? Most important is the awareness. Only 50% of the patients, I should say, that have hypertension are aware that they have it. So 50% is absolutely not aware, having hypertension. Key importance for you to know: hypertension is very prevalent, but it's also the most important modifiable risk factor for cardiovascular disease, the leading cause of mortality in Europe, stroke, end-stage renal disease, and peripheral vascular disease. So if you diagnose hypertension, you can affect it and you can change these outcomes. Despite intensive medical therapy and guidelines that we have over the years, ranging from 2000 to 2016, as you see here, no reduction in prevalence has occurred. So we try, but we're not reaching. With the aging population, as we start to seeing it more and more in the Western world, comes a huge increase in hypertension prevalence. You see here in blue the entire population of 18 and over. In a little bit lighter blue is 18 to 14 years. Greenish is 40 to 60 years, and then the light green is 60 and older individuals. Let's focus on the light green. The total population, light green, okay? 60% increasing prevalence in hypertension. Men, almost 60%. Women, almost 70% in the light green, indicating aging population, 60 years and older, huge prevalence of hypertension. Once you got hypertension, it has been shown over and over that it's associated with worse outcomes. And that's even worse if we leave it uncontrolled. So we need to detect it in order to treat it. And the earlier we detect it, the higher the likelihood that we can prevent these negative outcomes, that we can prevent these adverse events. Now I switch to the relation between hypertension and atrial fibrillation. How does that work? Why do we see so much atrial fibrillation in these patients with hypertension? Because long-standing hypertension, as you see in this slide, results in aortic stiffness. And aortic stiffness results in left ventricular hypertrophy and an increased left ventricular and diastolic pressure. So LVH, hypertrophy, and increased end diastolic pressure are the markers that are related to left atrial dilatation. And when your left atrium dilates, you get fibrosis in that atrium. And when fibrosis occurs, that is the trigger for atrial fibrillation. So non-treated hypertension results in increased left ventricular hypertrophy and an increased left ventricular and diastolic pressure. And that results in turn on left atrial dilatation, followed by the development of atrial fibrillation. So we need to diagnose to be able to prevent it. Early detection at home is the only way forward, because it's impossible that all these patients come every week to the general practitioner. So we need to go to awareness and self-detection. If we can detect it at home, it allows identification of patients possibly at risk for paroxysmal atrial fibrillation. And if we catch them early, we can treat them earlier. We can give them anticoagulation and we can prevent strokes. I'd like to conclude this introduction for the session. Hypertension is highly prevalent. Hypertension is associated with increased mortality. Hypertension is associated with cardiovascular disease and strokes. And hypertension is associated with atrial fibrillation. And atrial fibrillation, we talked about it, high risk of stroke. Early detection of hypertension and atrial fibrillation, both of them permits early treatment, and that can prevent adverse events. Thank you very much for this introduction, and now we start with the session.
I would like to share with you my perspective on the role of screening technologies, telemonitoring in the field of AF, and hypertension with an extension to heart failure and home care, because I believe this is one of the key elements of the future of cardiovascular medicine and beyond. And I will share with you my key arguments, and then at the end of my talk I will review with you a very, very brief case that I think supports that perspective. It's all on access to care, easy, fast, solid access to care, and improvement of outcomes by data analytics. And we know from various clinical trials and studies that high blood pressure and atrial fibrillation are really a dangerous couple. Does it make sense to take a look to technologies that put both states of disease, so to speak, in focus, not limiting it to arterial hypertension, not limiting it to atrial fibrillation, but combined technologies to have a more complete picture of where the patient stands. And it is well known, and there are good data, that both states of disease support themselves in the form of the classical vicious circle. So intervening, and the case gives rise to that perspective. Intervening on one side is not enough. You have to intervene on both sides to get the benefit for the patient. Home care and self-assessment will be key elements in the future of medicine. With, as I said before, with a regional aspect from European, North American perspective, but also with a global perspective. We have the privilege to have Ben Freedman with us, the head and brain of AF Screen, who's taking care for worldwide screening activities in the field of atrial fibrillation and more connecting to the world of hypertension. So Ben is also on the same track in order to get a more complete cardiovascular monitoring, screening, monitoring, and treatment. Treatment is really important, and I will come back to that point during my talk. Again, just measuring a biological signal is not enough. It does not change anything. It's the connection of the measured biological signal to a therapeutic intervention. That means that single point assessment in patients will not really help. But you need to be repetitively on the patient path continuously. Long-term access, they are relevant in chronic states of disease such as arterial hypertension and atrial fibrillation. We will take a quick look to the technologies, because technology is very, very important in order to apply the opportunities that are given by technologies in the best meaning for the patient to get the highest compliance, the best acceptance, and then at the end, the best results. And last not least, I just will go to one of the case examples. This is to remind us that when we see diagnosed atrial fibrillation and diagnosed hypertension, we just see the peak of an iceberg, of the iceberg. There are millions, if not hundreds of millions, patients around the globe with undiagnosed hypertension and atrial fibrillation. And again, the view to technology, now we have technology in our hands to change that, to increase the size of the iceberg, which is about above water level. And it will result in reduced stroke rate, in reduced heart attack rate, improved quality and quantity of life for the people affected. There's one clear message from this slide: 50% of the patients, regardless in what situation you look, have undiagnosed that have hypertension. It is undiagnosed. If it's undiagnosed, it's also untreated. Looking to the field of atrial fibrillation, we see that hypertension is one of the key elements in the field of reversible risk factors that needs to be addressed in patients with atrial fibrillation. And we know that hypertension control in patients with atrial fibrillation adds to the benefits that can be given to patients by advanced rhythm control strategies. So the advanced application of catheter ablation in patients with hypertension and atrial fibrillation is a combined package that we should offer to the patient. Just ablating the patient and then putting him or her on the road is virtually not enough. But the figure also shows that multimodal activities need to be rolled out in order to gain maximum benefit for the patient, as atrial fibrillation is driven and promoted by a set of comorbidities. And important is that many of these comorbidities can be reversed if we take the right and appropriate action. Home care applications will substantially increase. I've made that point already a couple of times. It will be telemedicine capable technologies to be connected, and that refers to the point that I've earlier made. Just measuring a biological signal does not change anything, but transfer of the message into a working and feasible system for structured data analytics and transferring the data analytics into change of treatment is the strategy that will at the end make the change and improve outcomes. Yesterday, we have seen the eBrave trial. eBrave was one of the late breakers. That was also a trial on the detection of atrial fibrillation. It was also an app-based trial, so technology, smartphone communication plays a key role. And not surprisingly, the eBrave showed, if you look closer, you see more. I mean, Ben, I think it has been shown in all studies with a different degree, different intensity that relates to the technology used. With continuous monitoring, you see different things as compared to discontinuous monitoring. With discontinuous monitoring, you can cover longer time frames usually and get repetitive measures. And at the end of the day, an intense discontinuous monitoring over longer time gets over the thumb comparable results as compared to continuous monitoring, let's say for 21 days. Connection to virtual care is the other element that I see in the future. I see digital technologies. I see intense self-assessment that goes far beyond the self-assessment opportunities that we currently offer to the patients. Connection to digital care centers, virtual hospitals. We have opened up a digital care center already in Berlin, and we will open up self-assessment centers for cardiovascular care in the next 12 months, where the complete initial onboarding and evaluation is done by the patient himself or herself. And it will, you may think I'm crazy, but I say it will include technical investigations that patients will do on themselves, such as ultrasound. It's all technically all feasible. I do not want to go into too much depth of the discussion, but think back 20 years when we saw 75-year-old people standing at the airports, and we believe they will not be able to onboard with the computer settings. And now you go to the airport, buses of retired people are standing there and onboard themselves the plane quicker than I can do it. So the general argument, no, people may be too old or maybe even not smart enough to go in self-assessment, is absolutely not true. And the technologies that are provided, complete technologies, blood pressure, rhythm, weight, temperature, facial viewing, all these elements will be put together and will substantially improve. I'm getting a little bit over time because I do not know, I haven't seen Jérôme, so I take another 1 or 2 minutes. Home care with blood pressure, there are good data that as compared to in-hospital assessment, the benefits are in this meta-analysis more pronounced for home care as compared to usual care. And it's interesting, the difference in that study, but the meta-analysis from 2011, it's not really focusing on up-to-date and modern technologies, does not include telemedicine as one of the key elements. If telemonitoring was applied, the benefits of home assessment were substantially higher as compared to non-telemedicine connected technologies. The quick case that I have prepared, I've recently treated a 52-year-old patients with highly symptomatic atrial fibrillation for a year. ERA 3, the man was a little bit obese with a BMI of 32, no other comorbidity. Antiarrhythmic drug treatment was done with flecainide that was not effective, so it was a class 1A indication according to ESC guidelines. He underwent catheter ablation with pulse field ablation. Pulse field ablation, this is not from the particular patient. This is an example from the work of Vivek, but it was the same technology. Pulse field ablation will absolutely change the interventional therapies in patients with atrial fibrillation because it's safer and it's substantially quicker as compared to traditional radiofrequency ablation. Why do I share it with you? Because it's important for follow-up and home care. We will do these interventions on an outpatient basis in 80% of all cases in very few years from now. Then the complete onboarding process, the onboarding pathway, and also the follow-up of the patients will be completely different as compared to an in-hospital setting. That means that we need technology that allow us to stay with the patient and to monitor rhythm and blood pressure and other parameters after the ablation intervention. And when it comes to healthcare economics, it will also be able to save a substantial amount of money if we go onto that path. So the investment into technology for home assessment is by far lower than the money that can be taken out of the cost bill when the duration of stay will be substantially reduced, and it's just a single day treatment. So he underwent PFA. He continued to have symptoms and palpitations, so he was not happy. I said, okay, lose weight, then it will get better. But you know, with losing weight, it's always a problem. They say, yes, I will do it, and the execution may be so-so. During in-office follow-up, he had sinus rhythm and a blood pressure of 125 and 80. We equipped the patient with a blood pressure and atrial fibrillation, the complete monitor for home assessment, and diagnosed arterial hypertension, and the episodes where blood pressure exceeded 160, 170 were the ones that still triggered episodes of atrial fibrillation. Atrial fibrillation was also documented with the installation of antihypertensive treatment. The patient was free of any further symptomatic episodes. My last slide is how we see the future of medicine in that setting. Digitalization and apps, self-assessment will play a key role, connecting to digital hospitals. The patient is connected, the ones that I shared with you, to our digital hospital, so I don't see him anymore. He is on a virtual path with our centralized doctors in Berlin and small centers for physical access to care that will, to a certain extent, replace the traditional settings in healthcare, will come to improve the quality of care around the globe. Thank you very much for your attention. So then I have the privilege to announce the next speaker, who has already joined us online, and we're looking forward to your presentation, Dr. Osman. Please.
Thank you very much indeed. Good morning, ladies and gentlemen. It's a great pleasure to join you for this session. My apologies, I'm not there in person, but because of technology, it's possible for me to present remotely, which is great. So I'm Faisal Osman. I'm a cardiologist and electrophysiologist working in Coventry at the University Hospital Coventry and also University of Warwick here in the UK. And I'd like to present some initial results of a feasibility study of using home ECG monitoring and blood pressure monitoring, a two-in-one device, from a patient and public's perspective. These are my disclosures. So we're all familiar with the ESC guidelines for atrial fibrillation and for hypertension. My two esteemed co-speakers, in fact, are co-authors of the AF guidelines, and these really set a guidelines, help us in terms of managing our patients with these conditions. The update from 2020 in the guidelines clarified how we diagnose atrial fibrillation, a recognition that increasingly we're now using technology with single lead ECG. So AF is diagnosed on a standard 12 lead ECG or 30 seconds or more of a heart rhythm showing AF on a single channel recording. And in those that were screen positive, this is established only after a physician has reviewed the tracings. The guidelines recognize the emergence of technologies, be they implantable, non-implantable, wearable technologies, usable portable technologies. They talk about opportunistic screening in those 65 or more, as well as systematic screening in those 75 or more, and increasingly the importance in certain risk patients, particularly those of an older age, and those who have hypertension. Now, we know there are 1 billion people affected by hypertension globally. When you think about it, the population of the Earth is 7.5 to 8 million. That's a huge number. 1 in 7 to 1 in 8 of us is affected by hypertension. Atrial fibrillation, we know, of course, is the commonest arrhythmia, and in combination with hypertension, significantly increases the risk of stroke. And stroke can be devastating. It has a huge impact on mortality, morbidity, and stroke prevention is a top priority globally, and particularly in Europe and certainly here in the UK. Now, in terms of emerging technologies, we have the Omron Complete device, which is a 2-in-1 blood pressure and single lead ECG monitoring device that can be used by patients, by the public at home. It relies on having a smartphone where we can download the Connect Omron app, and it uses the AliveCore technology in order to get the tracing of the ECG. So in our study, the aim of the study was to investigate the usability of this Omron Complete device with the users that we were looking at. We, broadly speaking, had 2 participants. The first were patients who were attending an EP clinic. They were offered the device for 2 weeks to take away, use at home, encouraged to use it a couple of times a day. And then they had some questionnaires and later a semi-structured interview by phone or in person. We also had a public volunteer group. So we have members of the public who have volunteered their time in order to help with research projects from a patient's perspective and give a patient's input from research studies and research trials. And we had 11 public volunteers who came to an interactive workshop and a focus group. This group of patients also then had questionnaires and a semi-structured interview by phone afterwards. Of the 15 that we recruited from the EP clinic, we did have 2 that withdrew. We collected quantitative data as well as qualitative data, and the latter was analyzed using thematic analysis. These are some of the baseline demographics of the 2 cohorts. So the mean age was around about 60, with quite a wide variation in age. People as young as in their 20s up to their 80s, a fairly even split in terms of males and females. You'll notice that 1/3 of our patients and public volunteers had hypertension already, the vast majority on antihypertensive medication. About 3/4 of our EP patients, unsurprisingly, had some form of atrial fibrillation that had been diagnosed. However, none of the public group were known to have atrial fibrillation at the start. In terms of owning blood pressure monitors, again, almost 2/3, just over 2/3 of our EP patients had a blood pressure monitor they were using at home, and that was even higher in the public volunteer group, where just over 80%. And unsurprisingly, very few, a much lower number, own their own ECG device. It was just under 10% in both groups. So what do we find in terms of the questionnaires and the user experience? So we used the Liebert scoring, 5-point Liebert scoring system, and we found that both patients and public volunteers actually had quite an overall positive experience in terms of blood pressure monitoring, importantly also interpreting that data. Our patients, EP patients, were very positive about using the monitoring, less so in the public volunteer group. And perhaps unsurprisingly, both EP patients and the public volunteers felt they needed more support with the tracings and interpreting what they were finding on the ECG rhythm strip. And this was much more so when you compare it in terms of the support that was needed for blood pressure. There was a significant difference in terms of the experience of the 2 groups. The EP patients felt it was more positive in terms of doing the 2 measurements at the same time compared with our public volunteers. In terms of benefit and the perceived benefit, both groups felt that it was actually very, very beneficial to record an ECG at the same time as doing their blood pressure monitoring. So a recognition that actually rhythm is important as well as blood pressure data as well. We then used thematic analysis to evaluate the EP patients and the public volunteers, and 6 key themes came from the EP patient group. Those were of patient empowerment, investment in health, device and user requirements, support, and also ergonomics of the actual device itself. And we'll go through each of these in turn. You'll see that there are some quotes. These are taken directly from the patient group. In terms of patient empowerment, patients felt they had greater control over their own health, and interestingly that they felt very reassured if the device said that there was no arrhythmia, if they, for example, were getting symptoms, that was reassuring to them and they felt greater control over their own health. In terms of investment, the group felt that they were certainly willing to pay and invest in these devices if it would help them maintain their health. In terms of device requirements, there was a need for good connectivity. Obviously, there was a need for having a smartphone in the first place. And the group felt that the most benefit would probably be in those who had underlying cardiovascular conditions or cardiovascular symptoms. In terms of user requirements, they felt it was a very simple system. It could easily be integrated into existing clinical pathways. One patient commented that it dovetailed very nicely into clinical appointments where they're able to collect their data at home and then show it to their clinician. The group was very, very keen to learn more about their ECGs and also to share their data with their healthcare professionals, be that their GP or the consultant looking after them. And in terms of the ergonomics, they all liked the design of the complete device. There was familiarity with existing blood pressure monitors, which I think helped. And they also commented that it was quite portable. It's slightly bigger than a smartphone, of course, but overall the consensus was that they liked the shape of it. In terms of the public volunteers, again, we had 6 key themes that came out from the thematic analysis of the public volunteer group. And they were a familiarity of the device with their existing blood pressure monitors, in terms of true value of where the device is, again, user and technical requirements, some comments about the design also, and some factors that would influence whether they would purchase the device or not. So in terms of familiarity, a lot of our public volunteers, over 80%, had a blood pressure device at home. So this was very, very similar. And in fact, the comment was that it was very useful to be able to take an ECG rhythm strip at the same time as doing their blood pressure. In terms of true value, again, this group also felt that if there were certain specific targets of population that were targeted with this, they would most likely benefit from these technologies. The group felt that it was quite simple to use once it was set up, and they also were very, very keen to learn more about ECGs and the tracings they were seeing. In terms of technical requirements, there was an acknowledgement that obviously if you didn't have a smartphone, then it would be difficult to use this. One particular volunteer mentioned that they couldn't buy it for their grandparents because the grandparents don't use smartphones. So again, we can get around this, and as Professor Hindricks has mentioned, the elderly population can be trained and do learn this sort of technology. They can pick it up. In terms of inclusivity and design, overall it was very well received. People thought it was a very good design with a very easy interface. There were some comments made about patients who may have limited dexterity, for example, arthritis, which is going to be more common in the elderly population, who might find it more difficult to use given the use of the device itself. And factors influencing purchase, there were comments about a well-known brand. So Omron was perceived as a very recognized and reputable brand, used extensively in primary care by our GPs, and this was something that was very positive. So in summary, ladies and gentlemen, the Omron complete device was positively received by both groups, and both groups felt that it encouraged patient empowerment. A basic level of technical skill was required, and where users needed that, the support would need to be put in place, and clearly a smartphone would be needed with this particular device. Users were eager to be educated on ECGs to learn more about their tracings, which would then help to facilitate their care at home. And they felt that there was a clear clinical integration and support that this device would certainly achieve. And these are all very, very important when we look at managing these patients. And these are 2 beautiful summary slides from the 2020 AF guidelines that highlight how the patient is at the center of everything we do. We have associated healthcare professionals looking after the patient, and these technologies can certainly help us in terms of our CC to ABC approach that the guidelines advocate. I'd like to thank Cleo White and Lucy Gilbert in our innovation team at the University Hospital Coventry, Warwickshire, and of course our patients and our public volunteers. I thank you for your attention.
Thanks, Faisal. Great presentation. Very, very interesting data. Congratulations for the trial that you have set up. It's very, very important that we fill the space with high-quality studies, such as the one that you have so beautifully completed. It's particularly interesting to be inclusive and to get the feedback from the patients, that we better understand patient perception, that we better understand patient preferences and wishes, and implement that into our technology and treatment pathways. One more time, I would like to welcome Professor Ben Freedman, who does not need any introduction in this circles, also know in other circles. Ben comes from Australia, and he is one of the key brains behind the idea of screening in atrial fibrillation. Ben was the first author of the World Heart Federation roadmap for atrial fibrillation, so he has a global perspective. And we are very grateful to you, Ben, that you are here and that you jump in.
It's nice to be able to jump in. and I also echo your views about what Faisal has presented. It's really important to hear the patient viewpoint. And I'm really pleased to see, but you have volunteers, for example, in the public, 80% of whom own their own blood pressure device. So that's an interesting group, but maybe not the most representative. And you also have people from an EP clinic who also are very invested in their atrial fibrillation and have a bit more information. But I can tell you that in a group of people, older people who've had atrial fibrillation in hospital, discharged in sinus rhythm, this is after non-cardiac surgery, we were able to give them a smartphone with an ECG device and train them to be able to measure it a number of times in their home. And a quarter of them had atrial fibrillation that was silent post-discharge. I really like the Omron, though, because it combines blood pressure and ECG rhythm strip in the one device. This is really essential because, as you said, Gerd, they are very bad bedfellows, high blood pressure and atrial fibrillation. Let me just give you one example. In the trial, the Loop study that was done in Denmark with volunteers, 4,500 people came. 1/3 had a blood pressure at the beginning of the trial that was 160 millimeters of mercury or more. 1/3. Although the trial was overall negative, the group that benefited was the group that had a blood pressure over 160. And this is 1/3 of the people in the trial. It's not a small subgroup. This is with intensive monitoring. I think that what we are seeing in the intensive monitoring and treatment is looking at one of the parts of the picture, because you need to control both blood pressure and you need to do the work we need to do on atrial fibrillation. So combining them together, the two most important reversible, preventable causes of stroke, makes good sense. And I think that older people can easily be trained to do this work with something that is simple in a combined device. So that's my take-home message from this.
Thanks, Ben. The floor is also open for question or comments from the auditorium. So if you have questions to the faculty, please go to the microphone and we take them. I have a question for Faisal. Based on what you have experienced and observed in your trial, what would be the next reasonable step in the field of clinical trials? What would be your idea where to go next?
That's a very, very good question. I just echo the comments that have been made by both of you about patients, just coming back to those points. I think in our group, we did have quite a few elderly patients. We actually did approach a couple who couldn't take part because they had no smartphones. And this is a fantastic device. The one thing I would say is that if some kind of display could be integrated in, so that the patients don't need a smartphone. I think that would be very, very useful. In terms of next stages, Gerhard, to answer your question, we are currently looking at a study of AF patients who undergo ablation. So as an EP guy, you will know this, the most frustrating things you do in ablation. We know patients have lots of risk factors that's caused the AF, and the AF comes back again despite a very good initial AF ablation procedure. And it's often risk factors such as hypertension, other things such as obesity, such as lifestyle, alcohol intake. All of these things contribute to that recurrence. And one thing that I think would be very useful in a study that we're currently working on is potentially to look at patients who are undergoing AF ablation, who have the AF ablation done, and to try and modify their risk afterwards, possibly with these devices. So the education is very, very important. Patients are educated and told, look, it's critical that you maintain good blood pressure control, cut back on your alcohol. Weight loss is a very, very difficult thing to achieve. We know that from the trials. But actually, I think the next step would be to see the intervention and the effects of these devices in clinical use. And I think certainly the AF ablation group would be a very useful one, I think, to study.
Thank you. We have questions from the floor, and we start with you. Please.
Hi, Leticia from Brazil. I would like your opinion about the difference between accuracy and how do you trust blood pressure measures with the arm cuff and the wrist cuff? I tend to find the wrist are not so replicable with office blood pressure, but the patients love their wrist devices. So I always advise them to buy the arm cuff one, but I'd like your opinion on that. Thank you.
I think in general, when we're combining the devices, I would go for an arm cuff because that's what, particularly in the older age group, this is what people are used to when they go to their general practitioner, or if they buy a device, it will almost always be an arm cuff. It's different, though, I think, for younger people or for people who are more interested and want to do it more continuously. I think there is a place for the wrist cuff. I'm not the best person to tell you about any combined studies or comparative studies, but it's really choice of the device for the person. And in the group where we're interested in looking for things, it's often in the older age group, in which case I would probably go for the wrist. If you're looking at more continuously, for the arm, and if you're looking more continuously, then the wrist has its advantages.
Next question. Yes, sir, please.
Abdullah Mohammed from the UK. I have a comment and a question. The comment clearly for preventative medicine, the future sounds great with digital hospitals and telemedicine. However, now, faced in the clinic with your patients with the smart devices and knowing the limitations of ambulatory ECG monitor, for example, utility and result is really not useful. How would you manage patients' expectations? Because now, when you're in the clinic, you would like to pick up more AF, you'd like to control the blood pressure, but then you're a very busy physician with many patients looking after. How do you manage your patients with those expectations? And of course, there are also medical legal implications. For example, if you say to patients, send me downloads from your smartphone on, AF when they have maybe topics or artifacts, and you're busy in your holiday or doing other things. How do you manage these things these days?
Thank you for the question. We take two perspectives. We start with Ben and then we go to Faisal.
I think in regular care, we have to change the paradigm of how we do it. But when a survey was done of physicians in 20 countries, 50 primary care physicians, in how often they took the pulse or checked for atrial fibrillation in the last 2 weeks, in people aged over 65, it was about 15% in the United Kingdom and about 11% in Australia. So even the very most basic office checks are not routinely done. So this is what is called routine care, but it's not so. So at least I think that's something that we should do. For the patient who wants to do more, it does involve some issues in this, and you need to have, if you are getting them to download and then send you their ECGs, this can be a medico-legal problem, but also a logistic problem for a single practitioner, and that's why I think we need to have a support for digital health, and I think this is somewhere where Gert is probably more experienced in and would be able to help you, but you need to have a setup for this.
Yeah, absolutely. Faisal, would you add to this?
Yeah, no, I would agree with the comments made. And I actually think it's a very good question, because I've been on annual leave. I've just come back. I'm scared to look at my emails. I've been away for a week. I don't know how many thousands of emails I'll have to clear. But the point is well made that patients, once they have devices, they are likely to contact us. And one thing we've found very helpful, certainly in Coventry, is we have very good arrhythmia nurses who are trained, who are cheaper usually than doctors, but they're very good at looking at traces, and they can often be an interface between patients and clinicians who often are very busy either in the lab or in clinics, etc. And I think having that support structure, and again, I'd echo the comments that have been made by Ben, having that support structure is absolutely critical. We have patients on remote monitoring at the moment as well, where arrhythmias are detected, and our cardiac physiologists are also excellent. They log in, they're able to review these tracings. They have a certain level of confidence in terms of looking at these rhythm strips, and where there's doubt, they can act as a filter and bring to us tracings where there is doubt or they're not sure what's going on. So I think we need to put structures in place, because it's going to come. We are going to get more and more patients contacting us, there's no doubt.
I mean, the structure is really crucial, and the problem is that it will not be just us who are initiating it or the patients who come to see us. What will happen is that the consumers, because these devices are marketed directly to the consumer, will come and say, you know, this is Dr. Google, the patient is ready to see you now. You will be confronted as doctors with people who've bought an Apple Watch or a smartwatch or a Fitbit or a Google or an Omron or a complete device, and they will say, my complete device diagnosed atrial fibrillation. And they will do this without any prompting from you. We don't yet have the confidence or even the training to be able to respond to consumer-led screening. And I think this is something we need to get used to, because it's here. It's not in the future, it's now.
That's a good concluding remarks from Ben Freedman. It's 11 o'clock sharp, and we have to close this session, this interesting session, on time. Thank you very much, Faisal, that you took the time during your annual leave to connect with us. It's a privilege to have you. Thanks for a great presentation. Special thanks go to Ben Freedman, who joined us this morning and enriched the discussion with his enormous expertise. We thank all of you for your interest in this session. We wish you another enjoyable day here at the ESC 2022 in Barcelona, and then safe travels home soon. Bye-bye.